Bismillahirrahmanirrahim. So, this lecture is kind of a basic lecture for the residents and students. When we talk about the nerve conduction study, EMG, naturally there are two pieces, even by the abbreviation NCS and EMG. NCS is nerve conduction study where we try to record the nerves, and this is usually done first compared to EMG, and we tend to do both studies because both studies kind of complement each other in terms of getting to the diagnosis. Now, talking about nerve conduction study, most of the nerves that we test are distal. So again, there are some limitations to that, but we can also test proximal nerves as well, which is not as common of a routine. But just remember, what I always used to tell for whenever I present nerve conduction EMG is that it is the extension of your examination. So whatever you guys gonna do on examination of the patient, you can prove it or disapprove it on the nerve conduction study. Initially, it does have some extra benefits of doing the nerve conduction study in our patients, and it does add some value. But I would love to hear what you guys come across on the service because as we are promoting getting more and more nerve conduction study, peripheral nervous system, starting from the interior horn cells, a little review, and also going to the motor nerve root, peripheral nerve. It could be motor or sensory part of it, but both are in the same peripheral nerve neuromuscular junction, and then the muscle. There is some differences between the motor piece and the sensory nerve root because the sensory nerve root goes to the nerve ends at the dorsal root ganglion, and from there, there is a sensory nerve root which goes in the dorsal horn. So when we do the recording, it's a little bit different because if a patient is having a root lesion, like you can look at the image too, that it will not affect the dorsal root ganglion or the cell body. So the sensory study gonna be normal in radiculopathies, which is kind of the basic. But do remember, based on the location of the dorsal root ganglion, it could be sometime more proximal to and inside the vertebral column or right at the neurofemoral location with the disc protrusion, there could be potential damage to the dorsal root ganglion. So it's sometimes damage to the sensory nerve root as well as ganglion in radiculopathy as well. But that is not a common phenomena. Many times, as I said, we do the nerve testing, and when we do the nerve testing, there is a sensory piece, there is a motor piece. So when we talk about the nerve conduction study, we do the acquisition, which is usually done by the technician team or resident or by me. What does it mean is that you try to stimulate the nerves, try to get some records, and do some measurements when you do that to get the velocity, conduction velocity. But this is something very important, which I'm going to talk about too during this presentation, which actually is very pictorial. So you guys will have some good visual interpretation of what I'm going to talk about. So after you do the acquisition of the study, the next piece is the interpretation, which I would prefer and I know my technician team, they do it as well, having kind of their own mindset or impression of the study, of what's going on. But then I would like the residents and fellows to do their own interpretation when they talk to me. So that will be helpful for me to add on top of that. And then how are we going to see those cases in the clinical context? So remember, like I saw one patient today who was diagnosed initially. And again, I'm feeling very ecstatic about these patients when we come across and try to consolidate a really tough case where the patient is having 2 or 3 peripheral neuromuscular issues in same patient, and there is some time kind of thing too. But it is very interesting if you don't have the clinical context and the exact question, you won't be, it's like shooting in the dark. So you won't be getting the good enough information to put your nerve conduction study and give a proper interpretation of what's going on with the patient. Purpose remains the same, which is localization of the peripheral neural axis and seeing where the pathology is. But as we discussed last time as well, many times The blood test and other testing is helpful in giving us the etiology of the problem. But to localize the problem in the peripheral neuroaxis, nerve conduction studies and EMG is very, very helpful. Again, with the nerve conduction piece only, what you can try to get is it a neuropathic problem? Is it a myopathic problem? Or is it a neuromuscular junction disorder? Second, nerve connection study guide us about the severity of the pathology. So that's why we tend to do study to see if there is an axonal injury and how bad is the axonal injury. Like the patient that I just saw today, when I saw the fun thing, patients see me and then come back after a year. They don't even coming back to me after 3 months or 2 months. So he saw me back then and I was comparing his studies. So the question was he having vasculitic neuropathy or ALS because of the amount of changes he has on the electromyography? So we ruled that out. So his changes improved. So we thought it is probably a one-time incident event, maybe viral myositis or something, or maybe vasculitic neuropathy, which improved, but more probably viral myositis because there were more muscle changes, like we just discussed. Now he's coming in today and he has a shot in his shoulder and his left arm is not working for past 6-7 years. Okay. Now the question is, there is a radial nerve injury, which was tested before and they agreed to it. But now he want to know, should he go for surgery or not? Then comes the point that I need to repeat only this study again because it's a separate question to be addressed, to know the severity of the pathology and to kind of give a localization where the surgeon going to go in. That's the same way when a patient is having a neck, like cervical radiculopathy question or lumbosacral radiculopathy question. You tend to do these studies before the surgery so you can quantitate how much there is improvement. Did something new happen after the surgery? Or is it the same pathology ongoing? Right? But fun part, many times in the rush of the fun of doing the surgery, surgeons, they don't refer the patient because they're going to delay too. It's a understandable factor there. But more importantly, at least you think of it. Same goes for the neuropathy patients who have neuropathy in the past. So sometimes you tend to do a repeat study to see where they are. Is there, like, I have a patient who's diagnosed as a vasculitic neuropathy, and I'm thinking, patient is complaining I'm getting weaker and weaker, and I want to know, okay, is it the treatment failure of whatever patient is on? Then you have to repeat the study to prove that point, how much axonal loss has been there in this period of 5 years or 10 years or whatever. So that's why interval studies can guide you about the progression of the disease, and also the study can guide you about the severity of the pathology. And we already talked about the temporal course of the illness. Finally, localization of the lesion, which is very basic. Is it polyneuropathy, plexopathy, radiculopathy, or it could be multifocal motor neuropathy or mononeuritis multiplex or mononeuropathy only. Let's start with the upper extremity nerve conduction studies. So usually the way I tend to do, I go by color code. So green is for ground. That's how I tend to remember. So, and actually these are the images from my own lab. So we use the stick electrode for the ground. When you're doing the hand, as I said, the most of the nerve conduction commonly done studies are distal. Try to apply the ground on the back side so you don't have to flip it again and again every time you're doing the sensory and the motor and the ulnar and the median. Once you got the ground on, it's gonna stay there. It will save you a lot of time, believe me or not. Okay. Then comes the temperature probe. Okay. I tend to keep the temperature probe on the palm. Also, you can have it on the dorsum of the foot or the plantar surface of the foot to kind of keep the temperature probe. This is something very important, and it's a big thing when we talk about the nerve conduction studies, especially demyelinating polyneuropathy studies. Then the way I tend to do, I tend to mark the areas where I'm going to put those recording and reference electrode. Not reference particularly. References, remember, generally 3 to 4 centimeter distal to the recording electrode. So this is for APB. This is for your ADM, okay? And this is for the sensory. So I kind of, because you're going to calculate the distance, which is also another important piece, because if you mix up even 0.5 centimeter, so it's going to make a big difference if you are mixing up 0.5 centimeter. So be careful when you are calculating your distance. So put the marks. That's what I tend to do, but everyone is a little bit different. But for the students and residents and fellows, I will really prefer that you guys mark it when you examine it. I tend not to use the red marker because it feels like you poke the patient everywhere and the patient is bleeding. Now, as we do the study, I tend to do the sensory study first before the motor study. The reason for that is because when you do the sensory study, you need a very small electrical current. It's like 3 to 5 milliamperes. Every time you shock, you go up by 3 to 5. But max by 30, you should get your max response for sensory. But for motor, because it goes higher, it's naturally more annoying and makes patient more uncomfortable. So sensory study is more to get them acclimatized to what you are trying to do with them. Now, I can go back and forth if you like, but we can read together. So you're going to put the recording electrode over the interphalangeal joint of the second finger, and then you're going to put down your reference electrode 3 to 4 centimeter or up to, you're going to put a distal interphalangeal joint. Then you're going to put the ground, like I said, on the dorsum. And then when you are stimulating, you're going to be at the mid wrist between the palmar surface of the hand, between the tendons of the flexor carpi radialis and palmaris longus. And it is done 14 centimeter proximal to the active electrode. Now, do remember these distances are fixed, and the lab normative or reference data is according to that. So try to stick to standards. But in case you did the study and you didn't realize that it was done on 13, so you can always correct that on the machine. If you don't want to go back and do it again, please correct the distance. Don't feel shy. You can always correct it. Okay. But in case you keep 14 and you did it at 13, that's going to give an impression that it was faster in that segment of the nerve. Also, I can give some idea to you guys. If you're going to look at the wrist, your own wrist, you're going to see two tendons in the middle, right? Those are your flexor carpi radialis and palmaris longus tendon. So usually you tend to stimulate in between, but believe me or not, the normal anatomy could be very, so you can go a little bit medial, a little bit lateral, but go very slightly if you do that. But believe me or not, you get the study most of the time there. Okay. Now, fun fact, in 15% of the patients, palmaris longus may be absent. More importantly, is the middle of the wrist. Okay. And don't try to simulate too much with the current, because then you will be fetching other nerves in the locality of the recording electrode. Especially if you're doing the motor sensory, median sensory, you may get the median motor study coming in too. But again, don't stimulate too much for the sensories. Go by 3 to 5 milliamperes. Don't stimulate too high. Above 30 is too much for sensory. Coming to median motor, and again, in that case, you're going to put the recording electrode at the center of the belly of abductor pollicis brevis, which is half the distance between the distal wrist crease to the metacarpal phalangeal joint. I can go back again. It's here, and this is your proximal interphalangeal joint or metacarpal phalangeal joint, and here's the distal crease. So kind of midway, you're gonna put that mark. And when you're calculating, now see this is such a big patch electrode. So when you're putting that patch over there, do remember to kind of measure the distance from the middle of the patch. That's what I do. If you're again measuring from the edge, it will easily make a difference in the conduction velocity and the latency. So be careful. You're gonna measure it from the middle, and you try to keep that middle on the dot that you had applied to. And sometimes if you are not sure if a patient is having atrophy of the muscle, you can activate the muscle to see where the maximum bulk of the muscle is to get the best study. Okay. Then when we are doing the motor study, you're gonna try to measure the distance, and the reason why we measure the distance in the motor study compared to the sensory study, because for the sensory study you are stimulating the nerve and getting the response at the sensory receptor. In case of motor study, then when you stimulate the nerves, it goes to the neuromuscular junction, to the muscle, and then you're gonna get the recording of it. That's why you need to get the elbow and the axilla or more proximal stimulation to kind of cancel out and get the exact number for the conduction velocity. So when we stimulate mid-wrist between the flexor pollicis, flexor carpi radialis and palmaris longus tendon, 7 centimeter proximal to the active electrode, and cathode should be facing the recording electrode. When you guys gonna do it, again, I can tell 100 things, but you will not remember it. But more importantly, if you remember the landmark, that's the best piece. Also, we do have the handouts you can always get when you come on rotation on the very first day or a day or two earlier, so you get yourself prepped when you come in the lab. For the elbow, stimulate proximal and medial to the antecubital space, just lateral to the brachial artery, or medial to the biceps tendon. Okay. Stimulation in the axilla, again, that is just 10 centimeter proximal to the elbow stimulation. Okay. And you don't need to go all the way in the axilla to do that. You can do the Erb's point, which is the neck as well. So Erb's point stimulation is another piece that we can potentially do, not routinely done, in patients where there is suspected proximal demyelinating process. So these are all those points that what we discussed. So you're gonna put the recording electrode, a reference electrode. This is your cathode. This is your anode. Okay, this is your elbow stimulation. This is the wrist stimulation, and you're gonna get those and measure the distance to kind of give you the idea about the conduction velocity. Okay. Now, this is something you guys may have seen me in clinic or when we do the nerve study. So there's a palmocutaneous sensory branch which actually leaves in the forearm, and it doesn't go through the palmar aponeurosis, and it supplies a thinner eminence. So many times when you are doing the pinprick assessment and you touch here, patients say, "Oh, I feel numb here." But actually, patient should be feeling numb here for carpal tunnel. Patient should be feeling numb here rather. Okay. So again, there is a recurrent thinner motor branch which supplies your muscle of the thinner eminence. Then there are palmocutaneous sensory branches, and there's a motor branch to the first and second lumbrical. As I said, you can do any nerve or muscle. So for the lumbrical muscle, you can do for axonal neuropathy patients. So you want to assess, is it because of the median neuropathy, or is it because of the axonal neuropathy when you compare that with the first lumbrical study with the second interosseous study, which is supplied by the ulnar nerve. So again, this is kind of the usual setup that I follow. I keep the temperature probe on the palm, so it's not I have to change again and again, because the rest of the points are open for me to do the study. This is again stimulating in the elbow to get the more proximal motor median study. Same for the median sensory study. You be careful about the distance, stimulating and recording electrodes. And also, like, if the fingers are bent, that will also reduce your distance. Okay, so be careful, keep your hand straight. As I said, mark where you're gonna put your electrode, recording or stimulating, and kind of go from there. Again, median nerve sensory study. For the G1, G1 is your recording, G2 is your reference, ground is on the back. What's Martin Gruber anastomosis? The best way I tend to remember that is me to you. So there are fibers going from median nerves to the ulnar nerve. So if you are doing a recording for the ulnar nerve at the ADM, which is abductor dis minimi, and you're stimulating at the wrist, you're gonna get a good response here, just like this. But now, as you stimulate ulnar nerve at the below elbow and above elbow location, it's gonna give you reduced amplitude here. And you're going to feel, oh, there is probably a conduction block because there is a criteria. If it drops by 50%, that's a conduction block. Okay. Now, if there's a conduction block, it could be demyelinating polyneuropathy. So that's why always be careful. So when you do that, what you're gonna do, you're gonna keep your recording electrode there, but you're gonna stimulate the median nerve at the mid-rest and the elbow region. Okay. And if you do get with the with the elbow stimulation, you do get the recording at the ADM, that is the missed piece. So it's a normal variant. It seems so simple, but believe me or not, there are 4 different types of Martin Gruber anastomosis. And fun is, instead of me to you, it could be you to me too. Okay. So ulnar nerve is the second most commonest nerve that we test in the upper extremity. So again, I will go for the ulnar sensory. First, place on the 5th finger over the proximal interphalangeal joint. And the reference going to be distal, okay, at the distal interphalangeal joint. The ground going to be at the dorsum. When I'm stimulating, it's going to be 14 centimeter. All these distances are mentioned on the machine as well. Like when you're doing the study, if you look at the machine, all these numbers are there. So don't worry. We want you guys to be careful, be mindful. But all these things going to be there. And just medial to flexor carpi ulnaris. Again, you can actually push the flexor carpi ulnaris tendon a little bit back and forth because yes, it could be medial, but it could be slightly lateral too. So, but 14 centimeter, you start low and see where you get the response. Once you get the response, at that time, move your stimulating cathode and anode, and you can kind of see where you get the best response. Okay, that's what I do or used to do. For the ulnar motor, again, you're gonna place at the muscle belly. Remember, these are digital sensory branches. For the motor study, you're gonna put at the belly of abductor digiti minimi. Sometimes it's helpful to palpate the muscle. So if you kind of ask the patient to open the finger, and you can do it on yourself too, you can feel your abductor digiti minimi muscle. And if you palpate it, it's really tense, and you're gonna go in the middle of it to get the best response. And the reference is distal over the 5th digit, where the same, and then ground on the dorsum. When we are stimulating, remember, when we are stimulating ulnar nerve, there is one extra point that we do. At the wrist is the same 7 centimeter proximally from the active electrode and just medial to the flexor carpi ulnaris muscle. Below elbow, when you do that, you have to bend the patient's elbow. Okay. So when stimulating the elbow region, you must flex the elbow to there is an angle of at least 90 degrees, but 70 to 90 is fine. Feel the ulnar groove and stimulate just below this area. Remember, if you're further off, there is possibility you may not getting enough robust response or stimulating the ulnar nerve. So try to keep this distance of less than 6. Actually, 4 is the best, but 4 to 6 is kind of, make sure you kind of get it as close possible to the cubital tunnel area or the ulnar groove. Above the elbow in the same 90-degree position, you're going to do stimulation proximal. And again, try not to go too far up. Try to keep it in again, 4 to 6 centimeter. The total distance between above elbow to below elbow stimulating points shouldn't be more than 10 centimeters. And you can go 10 centimeter proximal to the above elbow location to do the axillary stimulation to record the ulnar motor potentials. Sometimes in patients, we can do the dorso-ulnar cutaneous nerve. I'll come to the pictorial of that. It is a branch of ulnar nerve that actually leaves before the cutaneous sensory branch, which is in the wrist and can get affected with the Guyon's canal. So for the dorsal ulnar cutaneous nerve can guide you is like a ulnar nerve being affected in the forearm or at the wrist. So it is helpful in those cases. So place the recording electrode on the dorsum of the hand between the 4th and 5th metacarpal bone, and place the reference on the 5th finger, ground on the back, and also stimulating 6 centimeter proximal to the recording electrode in the pronator position. So remember, the hand gonna be pronated when you're gonna stimulate like 8 centimeter and medial to your flexor carpi ulnaris muscle. Okay, so this is the ADM or ulnar motor. So 7 centimeter. If you're gonna calculate from this point, remember the 1 centimeter gonna be here. So every number gonna be 2 centimeter with the solid l- long cutting line below that. So if we are measuring 7, that gonna be here. So again, every half centimeter makes a big difference. There could be people with the smaller hands, people with the large hand. So having that is very, very helpful and important. So you need to bend the elbow like you can see in this particular case. You're gonna go like this for below elbow and above elbow. Okay. Try not to go too high up. Keep these two stimulating points between 10 centimeter. So this is below elbow stimulation. Your cathode should be facing the recording electrode. And I tend to remember red as reference. That's kind of my way of remembering, not mixing up the electrode. So I always keep red as reference. So this is above elbow stimulation. Okay. Ulnar sensory, this is your recording electrode on the distal interphalangeal, your reference electrode, and then you're gonna stimulate 14 centimeter uh, medial to flexor carpi ulnaris tendon. This is a little smaller slide in terms of, but again, this is axilla stimulation of ulnar motor above elbow, below elbow, and at the wrist. And then you had the uh, dorsal ulnar cutaneous nerve under like in the pronator position between the fourth and fifth metacarpal phalangeal, fourth and fifth metacarpals. So you're gonna have your recording and reference electrode, and then you're gonna stimulate on the medial side of flexor carpi ulnaris 8 centimeter proximal. Radial nerve is the third nerve that we test in the upper extremities. Again, go for the radial sensory. We tend not to do radial motor as we have got enough information with the median and ulnar motor. But in rare cases, like I gave you the example of radial nerve injury, you should get radial motor study. Radial sensory is also helpful in patients where we are suspecting brachial plexus injury. Beside medial antebrachial cutaneous and lateral antebrachial cutaneous muscles, antebrachial cutaneous nerves, because those are kind of give us the idea, is it the medial cord affected or the lateral cord affected? And for the posterior cord, it's a radial sensory. So if you do 3, you already know what part of the cord is affected. And actually, you can do the needle exam to localize it more, but that is kind of screen when we talk about the brachial plexus injury patients. For the radial sensory, again, you're gonna place the recording electrode in the anatomical snub box. It's right there, and there is a tendon which is very obvious. You can palpate that tendon, extensor pollicis longus. Yeah, you can feel your nerve a little bit of a kind of crossing through that. But if you're gonna put your recording electrode there, reference electrode, a couple of centimeters down at the thumb, ground at the dorsum between the recording and active, and then you're gonna stimulate 10 centimeter proximal to the recording electrode on the dorsal surface of your forearm. For the radial motor, you're gonna place a recording electrode over the extensor indicis proprius muscle. So if you go 2 finger breadth above your ulnar styloid process and you try to move your index finger, you will feel the muscle. And you're gonna place your reference electrode on the ulnar styloid, and then you're gonna stimulate at the forearm, elbow, and above elbow. Forearm 8 centimeter proximal to the ulnar styloid, just radial to the extensor carpi ulnaris muscle. Elbow gonna be 6 to 8 centimeter distal to the lateral epicondyle between bicep tendon and brachioradialis. And brachioradialis is such an obvious muscle in the forearm. I don't think any issues with that, but you can always check your brachioradialis is right, the bulky muscle on the lateral side. And between that and the biceps tendon above elbow, you're going to stimulate at the spiral groove at the medial edge of the tricep with the external rotated and the forearm supinated. So this is a anatomical stuff box measurement. Again, you're gonna measure the distance, 10 centimeter or 9, and then you're gonna stimulate it. So see, if you are keeping your hand like that, you're already reducing the distance. So it should be kind of in a normal anatomical position. Coming to the lower extremity nerve connection studies. So when we talk about the lower extremity, again, talk about the temperature probe on the dorsum, ground on the plantar surface. Still, when we do the proneal motor, you're going to place a recording electrode on the extensor digitorum brevis, which is a small muscle. That is extensor digitorum brevis. It is a small muscle. It may be atrophic in some patients, but if you're going to make the patient move their toes out, you will see it. Apply your recording electrode over there. For the reference, you're going to place a reference 3 to 4 centimeter distal. Ground, we already talked about that, stimulating. 8 centimeter proximal between the medial and lateral condyles, or malleoli, in the middle of the ankle, and stimulating below elbow at the lower edge of the fibular head. Don't do it at the fibular head, because if you're stimulating harder, you can break fibular head. So be careful about that. So it has to be below the fibular head and lateral part of the lower knee. Above knee in the popliteal fossa, again, if you go a little bit lateral, that would be helpful. But again, that comes with a little bit of experience. Doing it in the fossa is harder. You have to bend the knee as well to get it deeper in the popliteal fossa. For the tibial nerve, again, you're going to place your recording electrode on the abductor hallucis. I'm going to show you that muscle. Feel for the navicular bone, which is the prominent bone. If you go down from the medial malleoli further down, the most prominent bone is the navicular bone. So you just go 1 finger breadth below that to apply the recording electrode. And then you're gonna place the reference electrode 3 to 4 centimeter distal. And then you're gonna stimulate 8 centimeter slightly posterior to the medial malleoli. I'm gonna show you the figure. Behind the knee, again, it's a little bit harder to get, but you need to flex the knee and do it a little bit on the medial side, and hopefully you will get it. For the proneal motor and tibialis anterior in patients where you are not able to get in like neuropathy, able to get any response measuring at the extensor digitorum brevis. So I tend not to do the neural exam for the same reason, because it's going to be affected many a times, not very, very helpful. But you can measure at the tibialis anterior to guide us, get the idea, is it a length-dependent neuropathy, which is the most common type of neuropathy. At the tibialis anterior muscle, at the lower ridge of the fibular head, 10 centimeter distal, because you're going to stimulate at the fibular head, below the fibular head. So you below knee stimulation at the lower edge of the fibular head, and then above knee in the popliteal fossa, you can stimulate and get the responses. Again, extensor digitorum brevis. Okay, measuring the distance kind of between the two malleoli, you're going to stimulate and try to get the recording. On the fibular head, you're going to go below the fibular head and also in the popliteal fossa on the lateral side to stimulate and get the recording for the proneal motor nerve. There is also an anatomical variant called accessory proneal nerve. Like when you stimulate at the ankle, you get some response, but when you when you stimulate at the fibular area, you get a bigger response. So then comes the question, what's happening here is probably because there is an accessory proneal nerve which gets an additional supply and get recorded when you're trying to stimulate at the fibular head. Again, this is your abductor hallucis muscle just below the navicular bone. And yeah, you can make the patient abduct the hallucis or the great toe to palpate the muscle. This is tibialis anterior muscle. This is for the tibial nerve behind the or posterior to the medial malleoli. This is again, navicular bone is here. Below the navicular bone, 1 finger breadth, where you're going to apply your recording electrode. And in the popliteal fossa. Then quickly about the sensory nerves. So there are sural, there is superficial proneal and lateral femoral cutaneous nerve, and these are the last slides. So for recording, you're going to place posterior to the lateral malleolus, about 2 centimeter, and you're going to place the reference 3 to 4 centimeter distal, stimulating 14 centimeter proximal from the active electrode near the middle of the gastrocnemius. And then you can work a little bit lateral to kind of get the best response. So that is for the pseudo assessment. And remember, this is what we call antidromic conduction. Orthodromic, when you're trying to do the measurement conducting towards the soma or the cell body. For the superficial peroneal, you're gonna place a recording electrode 1 to 2 finger breadth medial to the lateral malleolus between the tibialis anterior tendon and medial malleolus. And the stimulation is done 14 centimeter proximal to the active electrode along the interior and the lateral surfaces of the leg. Lateral femoral cutaneous nerve we can do next time, but that is an easy one that we do in meningeal parastatica. So this is for the sural nerve, your recording electrode behind the lateral malleolus, 14 centimeter proximal. You're going to start in the middle and move it out a little bit laterally to get the sural response. Superficial peroneal, again, you're going to apply your recording electrode and almost 10 centimeter proximal or 14, you're going to stimulate to get the superficial peroneal responses. I'm open to any questions. Please let me know.